I'd like to welcome Professor Michael Woodward to give our first presentation about beyond vaccinating against specific diseases, prevention benefits of other diseases. Thank you, Michael.
Thank you, Colleen. I think I've got an answer for the poor vaccination rates. The biggest killer is dementia. If we can actually better link vaccination with dementia, we might get people actually increasing their vaccination rates. And I hope in the next 15 minutes or so I can convince you that there probably is a link, not just with dementia, but other diseases, other off-target effects of vaccination. Now, of course, we've seen these sorts of slides before. Vaccination is part of what we need to do to live well. So to what we eat, exercise, some medications, heart health, not smoking, but vaccinations are a very important part of that equation. But what if it does more than just prevent RSV, ICU admissions, etc.? We know that vaccination is the second most effective intervention we can make on population health, particularly in low and middle income countries. We've seen some of this data yesterday. This is slightly older, but it shows the benefit of vaccination is actually only second to provision of clean drinking water. In older adults, vaccinations are done to prevent diseases. On the left, you'll see the diseases that are vaccinatable, but we also vaccinate to improve quality of life. Pertussis and shingles are probably the two best examples of that. Now, there's overlap, of course, between mortality and quality of life. We've seen from Paul this RSV data for older people. Older people not only can die from RSV, but they can become more frail. They are more likely to need hospitalisation, more likely to need institutionalisation. In fact, 40% of people before they were hospitalised with RSV over the age of 60 actually, I'll get the people controlling the slides to change it so I can see the other slide bigger if possible. 40% of people were living in institutions, living freely, beg your pardon, 60% in institutions, which shows that RSV is often a disease of the institutionalised. But after 6 months, that was down to 32%, an 8% or a relative 20% reduction. And there are many other facts here on this slide about why RSV is not good. It leads to frailty, it leads to dependency, it reduces quality of life. But are there other benefits of vaccination beyond prevention, beyond just getting rid of the disease? Well, let's look at the cardiovascular effects of flu vaccination. Remember, we talked about the various years of flu yesterday. 2007, I'll remind you, was a bad flu year. Now here, again, can I ask the audio-visual people to increase the left-hand side so I can see the slide a bit better? That's great, yes. So here you'll see that influenza vaccine in a univariate analysis reduced the risk of a cardiovascular admission to hospital in New South Wales, adults over 50, by 68%, and in fact 85% in a multivariate analysis. The other factors on these slides here are risk factors for a cardiovascular hospitalisation. But flu immunisation was preventative. And in fact, we know that pneumococcal and influenza vaccination, either individually or in combination, can reduce ischemic stroke, 33% if both are given, myocardial infarction and admission to CCU. This is Hong Kong data, and we actually had the head of the unit in Hong Kong that's done this research speak to us at an advisory board yesterday morning. So convincing is this evidence that the European Society of Cardiology, followed by the American College and more recently the National Heart Foundation of Australia and New Zealand, recommend that influenza vaccination be given to all patients of whatever age with acute coronary syndrome. Now, of course, that's also the recommendation for many age groups, even without cardiac disease. But I think it's relevant that the cardiac societies have made this specific recommendation if you've got an acute coronary syndrome, a non-STEMI, or if you've had a stent or something like that. Immunisation can have many effects. On the left, we see flu vaccination, a 56% overall reduction in cardiovascular mortality, a 36% in dementia. I'll come back to that. An overall risk reduction of 13% for ischemic stroke. And we see the same for shingles. Now, in shingles vaccination, we're obviously having a different mechanism of action. We're not preventing the infectious disease, we're preventing the reactivation of the virus. But it's interesting that the benefits of both shingles and flu vaccination are relatively similar with respect to cardiovascular mortality, ischemic stroke and dementia. Could this be a direct off-target effect of vaccination? Well, it's been known for many years that BCG vaccination for bladder cancer was associated with a reduced risk of dementia. Some have looked back at that data and think the methodology wasn't sound, but it provided a signal that's led to further research. It's hard to believe, of course, that vaccination against a specific microorganism could reduce disparate diseases. And perhaps the most surprising off-target benefit of vaccination has been this dementia risk reduction, which, as I said, is now the leading cause of death in Australia in both males and females. So let's look at Wales. They had a program introduced in 2013 with the live attenuated vaccine, the Merck vaccine, so that everybody at the age of 70 got vaccinated, but there was also a catch-up group for people who were 80 or less. This is the 70-year-old data. Now, by Wales being what it is, there was very little leakage into the private market, but 56% of those aged 70 were indeed vaccinated and then followed up for 7 years. And the incidence of dementia was looked at. It's well documented in UK health data, and the medical records there are quite probably one of the best kept in the world. And it compared vaccinated and unvaccinated. I worked in Wales, and I can tell you, you had one record for the whole of the state, whether you're hospitalised or in the community. It was a really, really good record, although they were paper-based when I were there. And what we found in this study is that the risk of overall dementia was reduced by 28%. More even so with vascular dementia, which is interesting. And on the right, just briefly, it seemed that shingles also prevented dementia. Shingles without being vaccinated prevented dementia. So there's something to do with attacking the virus or getting the virus that prevents you from dementia. Now, what I want to take home from this too is if shingles prevents dementia, and perhaps it does, we need more data, I wonder what's going to happen to people who have been childhood vaccinated in the next 60 years, because they're not going to get shingles. We'll have to watch that, but I won't be around to do that research. But here's a more, I think, even more interesting set of data, and this was published in Nature Medicine, because I said there was a catch-up group, and if you were 1 day older than 80, in other words, if you were born 1 day before the 2nd of September 1933, you did not get the vaccine. And as I said, in Wales, you didn't pay privately to get the vaccine. Well, very, very few people did. And then if you look, the risk of dementia is higher the older you are. In other words, the longer since the 2nd of September 1933. But on that very day when you became eligible for the vaccine, and this is following people up for 7 years, there was a complete disjuncture in the line of risk of dementia. It lowered by a significant amount, as you can see there. It's hard to believe that anything's different in other biological risk factors over a period of 1 day at the age of 80. And this suggests again that vaccination in this group of 80-year-olds was preventing dementia over the subsequent 7 years. This is a larger claims-based cohort from Texas using propensity score matching. Over the age of 64, they'd been free of dementia for 2 years, and then they had an 8-year follow-up. It looked at a number of vaccines, as you can see there, tetanus, diphtheria, acellular pertussis, shingles, and the 2 pneumococcal vaccines. And it showed basically the same effect across all vaccines, but in particular, if you look in the middle, if you'd had at least 1 dose of Zostavax and both jabs of Shingrix, your risk of dementia was reduced by 86%. And the number needed to treat to prevent 1 case of dementia was 14. It did seem, however, that the more vaccines you had, the greater the risk reduction. You can see the same with the combination of both polysaccharide and conjugate pneumococcal vaccine down the bottom too. So the conclusion in this study was that all 3 vaccine types reduced dementia due to Alzheimer's over the next 8 years from about 11 to 8%, or in other words, a relative risk reduction of about 25 to 30%. Possibly having more than 1 vaccine, particularly in 1 class, was even more protective. And I'm not suggesting everyone who's had Shingrix goes out and tries to find the live attenuated shingles vaccine. It's still around in some countries, believe it or not, but it's not the logical thing to do. Could this be an effect of the adjuvant? Tony's talked a lot about the AS01 adjuvant, which is in shingles and in half the dose in one of the RSV vaccines. Well, here's an interesting set of data that just came out last year now, 2025, looking at RSV, shingles, or both in terms of dementia risk reduction. And we do see in these vaccines a significant risk reduction and possibly an additive effect, in such that the having both shingles and RSV reduced the risk of dementia by about 37%. And that was true in both males and females. Obviously, these vaccines prevented shingles, as you'd expect. So it may be that it's the adjuvant. This doesn't prove it, of course, but it may be it's not the actual antigen, however it's presented, but the adjuvant that's having the effect. Now, in this large systematic review of a huge number of studies and participants, again looking at a large range of vaccines, including typhoid, BCG and rabies, followed up between 3 and 20 years in the individual studies, we saw an overall risk reduction of dementia by about 35%. That's the red triangle, red quadrangle down the bottom. That's probably the best data we're going to get. There are other studies, larger meta-analyses, etc. Now, of course, the problem with these studies is selection bias. Do healthy people who are not going to get dementia get vaccinated? And that's why I think the Welsh data is particularly helpful in reducing that bias. Might we just be preventing viral reactivation? We know there's links between dementia and HSV1. A recent study, however, of those who have dementia using an antiviral against HSV1 showed no benefit, but that's after the horse has bolted. That's after people have got dementia. And it's interesting that a protein linked with Alzheimer's called TDP43 and also amyloid itself are linked with antimicrobial activity. There's some theory that the main purpose of amyloid, which is the protein that accumulates in Alzheimer's, is to actually prevent or reduce infection in the brain. So this is an article that was published in Nature very recently, and it again pushes that hypothesis. I haven't got time to go through all the rationale, but if you look here, you'll see that there was a reduced risk of dementia over 5 years, and it was more so with RSV vaccination than with recombinant varicella-zoster vaccination than it was with the pneumococcal vaccination, suggesting that it might be that it's prevention of reactivation of the shingles virus, which of course is also known as human herpes virus 3, I think. Is that right, Tony? Yeah, HH3. It may be that preventing reactivation of HH3 is what's doing it, but that doesn't prove that it's just prevention of the reactivation of that particular virus, but it's very suggestive. So what's the significance of this potentially protective effect? I've concentrated on dementia. It's probably also true with other diseases. I've given you some cardiovascular data. I've briefly shown you some stroke reduction data. And there may be other effects of vaccination. We haven't talked about cancer reduction. Vaccination seems to be as protective against dementia as recognising risk factors such as smoking or sedentary lifestyle. There's a whole lot of population-based studies now looking at lifestyle intervention to reduce dementia risk. Look up the FINGER study if you want to. We've done Australian versions of those, one of them which was authored by the Senior Australian of the Year this year, Professor Henry Brodati, who I know very well. We need to actually consider that vaccination might be an effective approach, because although we do have new anti-amyloid therapies available, there's about 1,000 Australians right now who every 4 weeks, 2 weeks with one of the drugs, is being given an intravenous infusion of a monoclonal antibody to remove amyloid. But could we get just as much benefit from vaccination with greater safety and far less cost? These monoclonal antibodies, which are themselves a form of immunotherapy. We've talked about immunotherapy for RSV. We now have immunotherapy for established Alzheimer's disease. But these are very expensive, about $60,000 a year all up if you include all the tests that are required as well as the drug itself. These are the two monoclonal antibodies that are available. They work. They reduce the risk, the rate of progression of the cognitive symptoms substantially. And you'll see those lines are continuing to separate, suggesting that they are truly disease modifying. Unfortunately, there's another protein that's wandering around in the brain called tau, and that at the moment doesn't have any effective mopping up, but we're working on that. And this has led, this sort of information has fed into the most recent Australian and New Zealand Society for Geriatric Medicine position paper on immunisation of older people. You're the first people to see this. This hasn't even become public yet. It's going to be on the website soon. We hope these specialist guidelines will guide specialists who in turn will inspire primary care physicians to adopt these recommendations. And as we heard in, I think, one of the earlier talks today, not being on the NIP doesn't mean the vaccine should not be recommended, and we should never make assumptions about whether our patient can afford the vaccine. So we've recommended shingles vaccination, of course, flu vaccination, including, we'll add soon the recombinant vaccine. It's not on these recommendations because it's relatively new. Respiratory syncytial virus, COVID-19 every 6 months over 75. We've also recommended pneumococcal. Now, we got it right, as you are going to be hearing from Paul after me. The latest PBAC recommendation is for the Merck 21-valent vaccine, and we felt that that was the better vaccine. That's why we put it in our recommendations here. Tetanus, diphtheria, pertussis in particular. We've also dabbled into meningococcus, and I'm sure this list will expand as time goes on. So these are the specialist recommendations, and feeding into this is not just prevention of disease, but prevention of dementia, which is really important for we as geriatricians. How can this protective effect be explained? Is it an anti-inflammatory effect, or is it reducing the inflammatory response by reducing the severity of infection? Is it inciting an immune response in a sort of off-target effect, maybe against amyloid or tau? In other words, is it acting as an adjuvant? And I won't go, because of time, into some of the rationale there. The gut microbiome has also been linked with Alzheimer's, and perhaps vaccination can have a direct or indirect effect on the gut microbiome. Watch this space. There's one most recent, this is from this year, 2026, that showed that vaccination may be slowing the overall biological ageing. A large study, and they looked at 7 domains of biological ageing, and 4 of them were positively and significantly impacted by vaccination. And those 4 domains were inflammation, epigenetic ageing, transcriptomic ageing, and a composite biological ageing score. So vaccination to reduce ageing and to reduce dementia. So in conclusion, the benefits of vaccination do extend beyond preventing the target disease, in my opinion. And I think there's a lot of data to support that. Increasingly, specialist societies are recommending vaccination. The mechanism needs clarification. It's likely that we're not just preventing microbial activity or infection. And really, to further work this out, we need to move beyond simply observing that a virus is associated with Alzheimer's or that a vaccine is associated with protection. And instead, we need to meticulously map out the causal pathways, right from viral infection or vaccine stimulation to changes in synaptic protein expression and co-pathologies of dementia, such as TDP43 aggregation, which is often found with Alzheimer's pathology. Specialists like primary care physicians and the primary health care team in general must actively promote vaccination. We can't just leave it to the primary health care team. And we have a masterclass just devoted to specialists here in Melbourne in May. And if you've got any of your colleagues who are trainees in the relevant ologies or early and mid-career specialists, please inform them of the masterclass, which is on the Immunisation Coalition website. Thank you very much.
Thank you very much, Michael, for that very compelling presentation. I think we have time for just one question for now, and then we'll have a panel discussion. Tony.
Summary of the data, and I'm glad I've had Shingrix and Arexvy.
So you're not going to get dementia?
I think absolutely agree with your conclusions that it's uncertain what the pathogenesis is. The Geldsetzer group paper in Nature actually has evidence for both ASO1 and inhibition of varicella zoster, and the Polisky Schwab paper paints a picture of reactivation of varicella zoster predisposing towards dementia, which I think is fascinating. Yeah. Thank you.
Thank you. I agree.